Dr. Varghese, thanks very much for being flexible here. I know that we had, I think on our end, a comms issue, so appreciate you waiting and being patient there. Obviously, so Dr. Varghese came to us through Dr. Doug Johnston at the Cleveland Clinic. He's a cardiac surgeon and also specializes in intensive care there. So I know you've had a really intense few weeks, but we'll turn it over to you for your insights and to share so far what you've learned in New York.
And we're knee deep in alligators over here. But I will add, that's a great talk by Dr. Fletcher. And I just want to add a few points with respect to how we've had to surge over the last 2 weeks as COVID has hit New York City quite hard. The first thing I think is in cities where you might be getting an onslaught, there's a few things to consider that he brought up, and I'll try not to repeat things, but to just add to it. You're going to have a lot of extra staff around, and so starting to plan ahead of time what staff you'll be able to reassign to what duties and responsibilities is something that should happen early on. As it hit New York City quite hard, we were making all these plans on the fly, moving teams around and finding out who was available, who wasn't available. And so doing some of that strategic planning ahead of time will be quite helpful. A large pool is obviously the group from the operating room. Being a cardiac surgeon, and I run the CT ICU, the cardiac surgery ICU here at Mount Sinai with a team of about 12 intensivists. And we were able to pull from the cardiac operating room teams, our physician assistants, to come assist us in the CT ICU. Now, most of these people don't have the expertise to take care of critically ill patients. And so it's a lot of just-in-time training. And some people will be quite anxious to take care of sick patients, and these are really critically ill patients. And they're used to taking care of patients, you know, as they come into the operating room and as they drop them off in the ICU. And so we've had to do a lot of just-in-time training and buddy the inexperienced people with experienced staff. And that takes some time to organize because it changes everybody's schedules around. The COVID patients are very resource intensive, as you can imagine, because of the donning and doffing that has to occur. In addition to that, any procedure that needs to be done obviously takes a lot longer duration than in a normal patient. So if lines need to be done, intubations need to be done, even an IV or an arterial line needs to be done, you can be in the room for an hour. And so you need a larger team to look after a standard critical care unit. We have 2 cardiac surgery ICUs, one's 12 beds and the other one is 14 beds. In addition to that, Mount Sinai Hospital has 120 critical care beds at the main campus, and then we have 7 other hospitals in the system. At the main campus, as I said, we have a total of 120 ICU beds between the various departments. And when we first started out, we were admitting maybe 4 to 5 COVID patients to the ICU a day. Within 3 to 4 days, that started to grow quite rapidly, and we began to fill entire units. And so one of the things we always tried to do was stay ahead of the curve. So as soon as we started to open up one unit, we began to plan the next unit and the unit after that. What was the staffing model going to be? Where were the teams coming from? So we would never have to turn patients away. The emergency room was intubating patients left, right, and center, and the phone calls by day 4 or 5 were happening every half an hour, with the emergency room looking for beds to put the critical care beds to put the vented patients in. And so there was repeated meetings 3-4 times a day, planning the next ICU and creating negative pressure. So in most typical intensive care units, you may have 1 or 2 negative pressure isolation units. And that's the same here at Mount Sinai. We had to on the fly convert every room we could to a negative pressure room. And so most of our intensive care units have a window. The window was taken out, a board was put in place, a hole cut out of it, and then a HEPA filter was attached, creating a negative pressure room. Some of our ICUs have doors on them that can close, but some of our older units, the medical ICU or the surgical ICU, don't have doors. And so plans had to be put into place to install doors there. And so that sort of guided us as to where we would open up the next unit, knowing that some units required a lot more construction versus units like the cardiac surgery ICU, which all they needed was the negative pressure. We had doors for all the rooms, and so we moved patients from one ICU to the other as we filled up, based on how much or how quickly we can set up the next intensive care unit. So we started out really with our new intensive care units that all had doors on them, and then filled those up while we prepared the surgical ICU, the medical ICU, and a few of the other ICUs. And so that allowed us to surge and be able to accept the large volume of patients that started to come in around day 4, day 5. The just-in-time training was very important. You put a lot of people out of their comfort zones, and so it requires some pep talk and encouragement, and to let people know you're never going to let them do something that they feel uncomfortable with, and that you're going to have them trained and learn side by side with a buddy. And that's how we created our call schedule. We created one big call schedule for our advanced practice providers, so that as we pulled from various areas of the hospital, they were all on one call schedule. And we ensured that in each unit of 12 patients, we'd have one attending, one fellow, some trainees, and then at least 2 advanced practice providers. And that seems to be an appropriate model for the amount of the resource intensive nature of these patients. Once you start opening up units, you can fill up 12 beds within hours. And there's a lot of time required to line these patients up. Some of them come to you on high flow oxygen or BiPAP and require intubation. So in those first few days, there's a lot of effort and time to line these patients up and get them, and the majority of them will require intubation. After you've filled your unit up, things start to slow down a little bit, and you have a little more time to focus on the patients because they're all lined up and they're intubated. Now they're in this phase where, as most people have recognized, it takes about 10 days to 2 weeks for the cytokine storm and the SIRS response to resolve, and for the lung injury to begin to improve. And so I think there's a very early phase where you need to ramp up quickly, and once the unit has opened and filled its patients, you have time as the days progress, things seem to mellow down in that unit while the next unit is ramping up again. With respect to teams, as I mentioned, we designed a lot of teams similar to what Dr. Fletcher mentioned in London. We created a proning team, we created an intubation team, we created a line team. We created a palliative care team just for these patients. And initially we thought we had a prone team that would come by and prone patients. But as our volume of patients started to increase, and we're at almost 300 ICU patients, the one prone team couldn't do it. And so they began training every ICU on how to independently manage and prone patients. And then we trained the OR techs to be the prone team. We created multiple groups of OR techs that could go around the hospital and prone patients, because we were proning 15 to 20 patients a day, which is what we're doing now. And so we moved from one team proning to disseminating that knowledge across the intensive care units, and each intensive care unit owned the proning of their patients. And if you had concerns, you could always go back to the lead prone team to get advice and direction. And the same thing happened for our line team. We initially had one line team that would go around helping out, but again, as the units that were opening up and admitting were very busy, the other units needed lines done. So everybody we divided up the line team into a few line teams to help disseminate the work and get the job done. And finally, for intubations, we started off with an intubation team. And as, again, things got busy, we divided it up into each unit would do their own intubations, except if we had a high-risk intubation. We had a DART team, which is a difficult airway team that would have an ENT surgeon, an anesthesiologist, and an ER doctor present for the intubation as needed. The other thing to consider is building redundancy into your teams. You have to remember that there will be people that become ill during the process, and so if you try to design teams with just enough people, you will have people that fall ill, and then you'll be short again. So we've always tried to build in redundancy, and that's dependent on the size of your hospital system and what capabilities and resources you have. The education tool is very important, so we created a Dropbox where we released that to all the critical care faculty that could access that around the clock, and all our documents were there. As we created new policies and procedures, they were uploaded into that document so people could access them at any time. In addition, we created these short education tools. We had 4 30-minute sessions for people that were not familiar with critical care patients that involved management of the ventilator, donning and doffing, management of sedatives, and a couple other topics that were short 30-minute bursts that the critical care faculty took the initiative to run these short 30-minute sessions that were put on throughout the week. So people like OR techs or OR PAs or orthopedic surgeons could come and attend and learn the basics of critical care. I like their idea in London of having a whiteboard on the wall where they could circle things. What we ended up doing is these patients, they all start melding together in your mind, and they all sound the same. And so we have glass doors in every room. We partitioned them out so that we had an area for the current sedatives, the PF ratio, the last arterial blood gas, and the last vent settings. And so plans would be made really on that board, and as we'd sign out from one team to the other, we'd be able to see the latest numbers and what the overall plan and goals were. They were all written right on the board. As there's no visitors to the intensive care unit, we didn't have to worry about HIPAA violations. The other thing we had to think about when we were in a hospital system is, what do you do if the sister hospitals, the smaller sister hospitals, wanted to transfer patients? What are the criteria for transferring patients to the main campus? We decided to do ECMO only on one site, which is at the main campus. We made a few other decisions as to what would be done at the main campus and what would be done at the sister hospitals, and had a team of people that would really decide when we would transfer patients to the main campus, knowing that we had our own patients coming to the ER that we had to admit as well. With respect to ECMO, we haven't, it seems like the commonality among the institutions in New York is there are not a lot of patients that require ECMO. Most patients can be managed with ARDSNet protocol and prone positioning. We had a few patients that have required nitric oxide or epoprostenol, but that also has been limited. I think I'll stop there. See if people have any questions at this point.
Yeah, this is, again, phenomenal, Dr. Varghese. Thanks very much. The first one that popped up is, what units are the Overflow ICU patients going to?
So because we only have 120 beds, what we began to do was create intensive care units on our step-down floors that are normally regular wards. You have to remember that the census drops very quickly for various departments. So the orthopedic surgery census will drop, the ENT census will drop, the cardiac surgery patient census will drop. And so we began to amalgamate patients into groups on wards to free up space. So we put cardiothoracic surgery together with general thoracic surgery together with cardiology in one 40-bed ward, and that freed up 2 other units to open up critical care beds. And so these are floors that are not normally designed for critical care. The doors don't have windows on them. You can't see the patients as well. We attempted to get cameras in every room, but that was difficult to obtain on such short notice. And so it wasn't ideal conditions. And so we would try to put the more stable patients into these floor beds that we opened up as critical care beds.
Excellent. This is coming from Dr. Terry Yao in Canada. Most of our surgical services are divided into 2 and sometimes 3 teams that don't physically interact to limit attrition due to infection within one team. teams that aren't on stay away from the hospital. Have you had to do this, or how do you try to limit infection? Is everybody required, and is there no opportunity to have a team, quote unquote, off?
We tried to look at that model, but as we started bringing teams together from the operating room, from cardiology, it became very difficult just to create a schedule for that team that met everybody's needs. We have various union rules that had to be followed for people's schedules. Some people never work nights, and now they have to work nights. It became very difficult just to put one schedule together. And so we don't have specific teams for COVID units and non-COVID units. We've have intermingled the nursing staff and the physician staff. Thank God so far we haven't had too many staff members fall ill yet.
And that tees up the next question. Are you wearing N95s while interacting with all COVID and PUI patients?
Yeah, the PPE has changed on a weekly basis in New York, and same with the CDC guidelines. As we began to expect the patients, the first guidance was surgical mask with a face shield. 2 days in, that shortly changed to N95 masks every time you're in the room. And that's where we are at this point, is N95 mask every time you're in the room with a face shield. It's remained that way throughout the hospital. There have been some concerns from staff that they feel more comfortable with N95 masks. So we've have allowed N95 masks outside the COVID units because we've had cases of COVID in non-COVID units. And so to protect the staff and protect the patients, we're allowing N95 masks in non-COVID units as well.
Great. And then last question, and I know we'll be respectful of your time and those who are running late here, but any special considerations for use of nitric oxide in these patients given aerosolization?
If we're using nitrous or nitric oxide?
The question said, yeah, nitric.
Yeah, nitric oxide. So nitric oxide on the intubated patients is in a closed system. So it's inhaled directly through the ventilator into the endotracheal tube, so there's no risk for aerosolization. The one area that you could be more concerned about is the use of high flow oxygen and face tents and face masks. We initially had some concern about that, but if our options are, if we're in a negative pressure isolation room, we have been allowing for high flow oxygen, for face masks in these patients. But with nitric oxide, it's usually occurring in the intubated, sedated, paralyzed patient, and the risk of aerosolization is low.
Well, phenomenal. Again, Dr. Varghese, I really want to thank you here. About at the peak, about 60 folks from around the country listening, so this is super valuable. Really appreciate making time. We will take this, synthesize it into Slack for folks, and then if I know that you're strapped, but if people do have questions, again, we'll route them through our team and send them your way. But thanks for stepping away from what I know is a crazy week.
My pleasure.
Great. So we'll wrap up here. I know folks we're running up against the hour.